When approaching the deteriorating or critically ill patient, use the systematic ABCDE approach. ABCDE stands for airway, breathing, circulation, disability, and exposure. First, ensure personal and patient safety and wear personal safety equipment such as apron, gloves, and glasses when appropriate. Perform an initial first look at the patient to see if the patient appears unwell. The initial look should take about 30 seconds. If the patient is awake, ask, "How are you?" And if he appears unconscious, shake him and ask, "Hello, are you okay?" If he responds normally, you already know that he has a patent airway, is breathing, and sufficient cerebral perfusion for now. Monitor vital signs early and attach a pulse oximeter, ECG monitor, and non-invasive blood pressure monitor to all critically ill patients as soon as possible. Insert an intravenous cannula as soon as possible if indicated, and you may use the cannula for blood investigations on insertion. When using the ABCD approach, remember to look, listen, and feel before you measure and do. Treat as you go and re-evaluate effects of treatments and interventions. Recognize when you need extra help and seek expert help early on. Use all members of your team, be an assertive team leader, and use effective communication tools such as SBAR and closed-loop communication. Summarize and re-evaluate frequently to establish a shared mental model. In the next couple of minutes, watch this video and you will see one little example of how it can look when the ABC algorithm is in use. Remember that the ABCDE is for alive patients, so we have already established that the patient has a pulse and is breathing. Hi, Johannes, you called?
Hi, Sandra. This is Mr. Jensen.
Yes?
And he just arrived to the emergency department and he has trouble breathing.
Okay. Well, let's assess Mr. Jensen using the ABCD approach, and let's start with the airway and see how he's responding. Hello, Mr. Jensen. How are you feeling?
I don't feel so good. I've been sick for a couple of days now, and I'm having trouble breathing.
You're having trouble breathing. Okay, but we'll take good care of you now. So Mr. Jensen is answering our questions, and he has a patent airway.
Yes.
No signs of airway obstruction. Could you administer 15 liters of oxygen?
Yes, I will administer oxygen.
And I will move on to B. I will have a look at Mr. Jensen's chest movements to see if they're symmetric. And they are. I will feel. There are no signs of cyanosis. Could you count Mr. Jensen's respiratory rate?
Yes.
While I listen to his breath sounds? And the respiratory rate?
It's 24.
Okay. Maybe since he's having trouble breathing, we should sit Mr. Jensen up.
Yes.
Can you do that? And then attach the saturation,
Yeah.
the pulse oximetry. So Mr. Jensen complains of having trouble breathing. He has a saturation of 90-91 and a bit fast respiratory rate.
Yeah.
So maybe we should do an arterial blood gas as well.
Yes, I will do that.
Thank you. Thank you. And then we can move on to C. I'll have a look at Mr. Jensen's skin color and check for any exterior bleeding. Could you measure Mr. Jensen's pulse?
Yes.
And measure the blood pressure while I do that?
I will measure blood pressure
Yes.
and pulse.
And he's not pale and there's no signs of bleeding. I'll check his capillary refill time. 4-5. It's normal. And I will listen to his heart. Quickly attach the CT as well. Heart sounds are normal. And Mr. Jensen has a blood pressure of 96/64, so he's a little bit hypotensive and his pulse is 116. So could you insert one large IV cannula and hang up 1 liter of saline?
Yes, I will do that.
Yes, thank you. And while you do that, I am going to move on to D. Let's check Mr. Jensen's pupils.
Yes.
Could you measure Mr. Jensen's blood sugar?
Yes.
Mr. Jensen, can you move your arms and legs for me? And he's moving. That was D. Let's move on to E and have a good look at Mr. Jensen and see if we've missed anything, if there's any rashes or edemas. And there is not. So we've assessed Mr. Jensen using the ABCD approach. He came in having trouble breathing. He was a bit tachycardic and somewhat hypotensive. And now his heart rate is down to 90, his saturation is up to 96, and the latest blood pressure is 112/75. So we're pretty safe right now, and we can investigate everything further. When assessing patients' airways, remember that airway obstruction is an emergency. Seek expert help immediately. Untreated airway obstruction causes hypoxia and risk damage to vital organs and put patients at risk for cardiac arrest and death. Create space around the patient. Remove the headboard and pillow if you need to work around the airway. If any visible vomit, blood or saliva is present, use a wide bore rigid sucker to remove liquid from the upper airway. Basic airway techniques can be used to relieve an obstruction when recognized. Place one hand on the patient's forehead and tilt the head back gently. Place your fingertips of the other hand under the point of the patient's chin and gently lift to stretch the anterior neck structures. Identify the angle of the mandible. With the index fingers and other fingers placed behind the angle of the mandible, apply steady upwards and forward pressure to lift the mandible. Using the thumbs, slightly open the mouth by downward displacement of the chin. If you need to backmask the patient, use a two-person technique as shown here in the video, combining the jaw thrust with a helper performing the ventilations. You may also make use of adjuncts in basic airway management. The nasopharyngeal airway is well suited for patients who are not unconscious and therefore will not tolerate the oropharyngeal airway. Pay attention though. If you suspect a possible base skull fracture, use an oropharyngeal airway, as insertion of the nasopharyngeal airway may, however rarely, lead to insertion into the cranial vault. When inserting the nasopharyngeal airway, check for patency of the right nostril. Lubricate the airway. Insert the bule first, vertically along the floor in a slow twisting movement. If any obstruction, stop and try the other nostril. Once in place, look, listen and feel. Chin lift and jaw thrust may still be required. The oropharyngeal airway is well suited for the unconscious patient. Use this technique when inserting. Open the patient's mouth and make sure there are no foreign objects that may be pushed into the larynx. Insert the airway into the oral cavity upside down. When you feel a little resistance, rotate the device 180 degrees, advance it until it reaches the pharynx and the device is situated between the patient's teeth and gums. A successful placement is indicated by improvement in breathing. Remember, a jaw thrust, head tilt, and/or chin lift may still be needed.